Today I'm talking with Dr. Dialecti Voudouris. She is a clinical assistant professor of medicine at the Mount Sinai School of Medicine and an oncologist working at Manhattan Cancer Specialists. Welcome, Dr. Voudouris.
Thank you.
Tell us a little about yourself and your clinical background.
I'm a community oncologist. I am affiliated with two major academic medical centers, and I'm in a group practice in an urban setting in Manhattan, as a matter of fact, with a few oncologists, several nurses, nurse practitioners, and we treat all different tumor types, mostly solid tumors, with breast, lung, colon, and prostate being the major cancer types that we treat.
We'd like to talk today about metastatic colorectal cancer and specifically about your approach to managing toxicities in the therapies. Which first-line regimen do you prefer to use and in which patients?
So metastatic colorectal cancer has evolved quite a bit in the past 20 years. There was, for many, many years, we really only had two drugs, 5-FU and leucovorin. And many years later, about 15 years ago, we had a drug called irinotecan, which we added to the IFL regimen, which greatly improved survival. However, that wasn't enough. The FOLFOX regimen, which is a combination of 5-FU, leucovorin, and oxaliplatin, difference between that and the IFL regimen is, of course, the oxaliplatin and the infusional 5-FU really did add to the median overall survival of patients who received it. We also have a combination called FOLFIRI, which is 5-FU given by continuous infusion, leucovorin, and irinotecan as well. And that, again, different from the IFL regimen because of the infusional 5-FU. We also have a variety of biologics that we can add on, such as bevacizumab, panitumumab, and later on of course, Erbitux. So, and later on, if patients progress, we also have regorafenib. So there are many, many different combinations along the way. So what we generally start off with, I really take a look at the patient and see what they want to get out of their treatment. And of course, everyone wants a cure. Well, we can't promise patients with stage 4 cancer a cure, but we can tell them that we have evidence-based medicine to provide drugs that improve overall survival. We also have other manipulations, such as surgery. So we do surgery on these patients, sometimes on the primary and sometimes on the metastases. We also have things like that the interventional radiologists do, such as radiofrequency ablation, as well as radioembolization with radiolabeled spheres, which is a very interesting approach. But the mainstay is chemotherapy. So first line, I really encourage patients to have, which is also recommended by the NCCN, which is an infusional 5-FU-based chemotherapy. And really, I look at what I'm going to add to my chemotherapy base and what are the characteristics of the patient. So I really try to add a biologic when appropriate. Of course, we have the KRAS situation. We first want to know if a patient is KRAS wild type or KRAS mutated, because there's some drugs that don't work as well if a patient is a KRAS mutation. And so if a patient is KRAS mutated as well as KRAS wild type, bevacizumab is a biologic that we want to add on. And so as far as the backbone chemotherapy, also looking at tolerability. So my preferred first-line chemotherapy regimen is FOLFOX plus minus a biologic.